My name is Dr. Eric Anderson. I'm Director of Interventional Pulmonary here at Georgetown University Hospital. My job entails the diagnosis and staging of lung cancer for patients who might be at risk for lung cancer. We screen patients. For patients who have been newly diagnosed with a lung nodule, we help to find out what the cause is. And once you've been diagnosed with lung cancer, we do the important staging of the patient to find out if any lymph nodes are involved in the chest. Once you've been diagnosed with lung cancer, my job also entails helping to treat it with the different modalities with radiation and treatments for endobronchial tumors that are inside the airways. At Georgetown, we have all the pieces of the puzzle for taking care of you if you have lung cancer. We have seen changes from improvements in lung cancer screening with a survival benefit. We now have technologies available to us to do a biopsy and stage a patient in a less invasive way. And now we have even better ways to treat patients that don't cause pain or discomfort and potentially even cure the patient. For a patient with early stage lung cancer now, it's a great joy to watch their tumors disappear after treating them with CyberKnife and having no symptoms from the treatment. This is a very exciting time for lung cancer, and we hope these advances will start leading to a better outcome for our patients and a better survival rate long term. Very exciting news has come out this past year with our results from treatment of lung cancer with CyberKnife. CyberKnife is a type of focused radiation, and it takes many beams that are the size of pencils and aims radiation directly at the patient from, on average for lung cancer, 150 different directions. This is different than conventional radiation, where the radiation is aimed from front to back and is given to patients over 6 weeks. CyberKnife radiation involves a beam directed from a robot arm from many different directions, and we give patients 5 treatments over 1 week, and they're finished the treatment. Because it's so short a course of time and because it's so highly focused, we can limit damage to surrounding tissues and provide a very high dose of radiation to the treated tumor. The first thing we need to do to treat somebody with CyberKnife is place small gold seeds in or around the tumor. These seeds are used by the CyberKnife machine to localize the tumor. When you're in the treatment room, beams will be directed at the target, and the only way the machine can see this is by taking X-rays through you. The X-rays will line up the gold seeds that we place and allow us to more accurately pinpoint the target that we're treating. To place these gold seeds, we do it by either bronchoscopy or CAT scan guidance. For a small tumor along the periphery of the lung, we can do that with a CAT scan, which involves a similar procedure to a biopsy. A needle is placed through the side of the chest wall, and a biopsy is taken if the patient has not had a diagnosis yet. And at the same time, a needle is used to place the gold seeds. If we do it by bronchoscopy for more central tumors, tumors along the airway or along the middle portions of the lungs, we can put the patient under anesthesia and do a bronchoscopy, a small camera that is fed down through the airways, which is painless. We are allowed to guide into the periphery of the lung and then use a small needle to insert the gold from the inside of the airway into the target or around the target. Once the gold seeds have been placed, the patient waits about 1 week before having a planning CAT scan done in the CyberKnife suite. The doctors will then use that information to do the plan for the treatment, which then begins usually the next week. Treatments will be 3 to 5 treatments, each lasting about 1.5 hours long, with the patient lying on a table, watching the machine move about them, aiming the treatments. The treatments are painless and are very well tolerated by the patients. When we ask them if they have side effects, the main side effect has been fatigue. If a tumor is located immediately adjacent to the surface of the lung, it's possible that they could have some discomfort. Most patients are relieved by Tylenol or ibuprofen. Everyone else who has tumors in the central areas are not expected to have significant side effects from this treatment. The ideal patient with the lung cancer is someone who has a small early-stage lung cancer who's inoperable. A patient may have significant emphysema or heart disease and not have an option for surgical resection. In these patients, the CyberKnife is ideal. The tumor is small and we can eliminate it with a very high chance of success of curing the patient from the cancer. When the patient has lymph nodes that are spread to other places, then it's no longer a good candidate for this treatment. Other patients who may benefit from the CyberKnife for treatment of lung tumors include patients who have been previously radiated. These patients have had conventional radiation to the middle of the chest, but may still have an option for giving additional boost of radiation to treat a single area that may become a problem. In addition, patients who have cancer that is traditionally insensitive to chemotherapy or radiation may be a benefit for a single treatment with CyberKnife. Patients with melanoma or sarcomas or kidney cancers usually do not respond to radiation, but because we give a very high dose of radiation in a short period of time, we can give a good response to tumors that have traditionally not responded well to conventional radiation. The CyberKnife can be used to treat metastatic disease that has spread to the lung, including tumors that are less sensitive to conventional radiation. Tumors such as kidney cancer and sarcomas and melanomas may respond to the CyberKnife when they don't respond to conventional radiation. So if your tumor has spread to the lung and has a single place which is become a problem, this may be a good option for you. At Georgetown, we've been treating patients with lung cancer with CyberKnife since 2004. We've treated more patients in the world with the CyberKnife for lung cancer than any other center. Our results are looking very good for patients who have stage 1 early stage lung cancer. At 4.5 years of follow-up on these patients, we have a survival that is comparable to surgical resection, with a very good local control rate of over 85%, and a 5-year survival of at least 70% in our early survivors. You should come to Georgetown for your treatment because we have the most experience with treating lung cancer than any other center in the world. We have treated more patients since 2004 with lung cancer than any other center. Our team is very experienced and we have exceptional results for patients with early stage lung cancer and good results for patients who have had recurrent cancers that needed focal therapies to help them. There are many new advances in technology for the diagnosis and staging of lung cancer, and we're very lucky here at Georgetown to have many of these available to us. The most recent additions have been endobronchial ultrasound and superDimension electromagnetic navigational bronchoscopy. The endobronchial ultrasound is an important tool for staging patients who have been diagnosed with lung cancer. This involves a flexible bronchoscopy with a camera placed down the airway, and at the end of the bronchoscope is a small ultrasound probe that allows us to see on the other side of the mucosa. That allows us to see the lymph nodes in real time and place a needle directly into the lymph node with real-time visualization so we can see that we are sampling the lymph node. This has led to an increase in our yield for diagnosis for the lymph nodes in the middle of the chest. Importantly, if you have been diagnosed with lung cancer, we need to know where it has spread to and which lymph nodes are involved. This technology is minimally invasive, is an outpatient procedure, and has a high yield of diagnosis. When coupled with the use of endoscopic ultrasound biopsies, we now can stage the mediastinum with cameras and small scopes and no longer need to use surgery to find out if the patient has spread of their cancer to the middle of the chest. SuperDimension is an electromagnetic navigational bronchoscopy. It is like doing a GPS system for your lung instead of for your car. It allows me to guide a bronchoscope out to the periphery of the lung in a more accurate fashion so that we can find and diagnose small lung tumors or lung nodules. The advantage of this over conventional bronchoscopy is that it is not limited by the large airways where the scope can go no further. We have a small tool that is able to be placed beyond the smaller airways and tracked using an electromagnetic navigational field around the patient. This allows me to use the virtual images generated from a CAT scan to guide a probe into the periphery of the lung. And when we get close to it with better accuracy, we can now biopsy and place fiducials for CyberKnife, or perhaps even treat lung cancers with other modalities through the bronchoscope. Traditionally, CAT scan guidance was the only way that we could reach these small nodules accurately. And there are risks with doing a CAT scan guided biopsy that could potentially collapse your lung in about 25% of the time. There's also a risk of causing hemoptysis or coughing up blood as a result of a CT guided needle biopsy. With bronchoscopy done through the airway and doing biopsies with superDimension, that risk of collapse of lung has been reduced to less than 1%, and the risk of bleeding is only 1 or 2% as well. In addition, we have a more accurate biopsy performed of these nodules. In the past, with bronchoscopy, a small nodule could only be biopsied and got a diagnosis in 25% of the time. But with this system, we've been able to increase it to at least 70%. A good candidate for superDimension is a patient who's been found to have a small lung nodule. A nodule that's traditionally harder to get by conventional bronchoscopy, maybe further out in the periphery, but as long as there is an airway that can be seen leading into this on your CAT scan, you may be an excellent candidate for this kind of biopsy. And it may be a safer way of getting a diagnosis than the previously used CAT scan guided biopsy.